All right, so welcome. All right, so we already talked about PK Scheerle just a little bit. I know y'all all know who she is, but you may not, and that's okay. So everyone knows she's the CEO of Gifted Nurses, and this professorship is in her honor and her contribution. So we thank her for that. We wouldn't be able to do what we're doing right now. So we are doing research when it comes to the student aspect, but for y'all, the faculty, we really want to do a QI project, which is different from me. So Dr. McCauley is leading the QI. So did everyone have a chance to do the survey link for the form that we sent y'all this morning? If not, we can take about 3 minutes and fill it out. Melissa, thank you so much for going around and getting that done. We appreciate that.
Jess, did you say no?
No, I did it. It's done.
I did not do it.
Okay. Do you see the link, Nanette? It should be in your email. About, let's see, about 8
o'clock.
Yeah, 8 o'clock this morning?
It came from me. The first link I sent, Melissa couldn't access it from a non-LSU computer, so I went and revised it so that anyone could access it. If you're using your LSU computer, you shouldn't have any issues with the email that went out at 8. Otherwise, I replied to that email and resent the link after I set the settings to allow access from anyone.
And that's probably just going to be myself and maybe Lori. Marco is looking into it, but since we're adjunct faculty, he was saying they may not have enough licenses for us to be able to use like OneDrive and forms and stuff like that.
Okay.
And you know what? And if that is so, I don't mind sending it to you in a different format, even PDF, and I can manually enter it, and you can just put, a unique identifier, and I'll anonymously enter it in as best as I can.
I think once I changed those settings, it allowed her to access it because it wasn't restricted to just LSU.
Yeah, I was able to do it the second time, so thank you, Sharon.
Well, I may have to use the second link because I used the first link and I'm at work. I'm on campus and it says, sorry, something went wrong. Please make sure you have permission to access this form. So let me try the second link.
Yeah, try the second one because it may be because I changed the link.
Okay.
So the first one may not work for anyone since I changed it.
Got it.
Got it? Good.
Perfect. So we'll pause just a minute.
Done.
Fantastic. Thank you. Okay. So at this presentation today, we want to understand the origins and the development of the INACSL standards of best practice and identify the simulation design criteria for the INACSL standards of best practice. So the first standard is the design criteria, and you will see as we go through it, it's kind of an umbrella that goes over all of them in little pieces. So we will touch on them briefly, and then the other parts of this series will explore those on a deeper level. So kind of an intro to everything today. Okay. So a little video.
So those are some of the terms that we're going to be learning about a little bit more in depth or covering again today. So if you didn't have a chance to look at the books or even receive them, what you may be asking, okay, what is INACSL? What does this stand for? So INACSL stands for International Nursing Association for Clinical Simulation and Learning. So it's got a pretty straightforward name. Basically, as simulation-based education grew as a key modality for nursing education, sim experts recognized the need for some structure, standardization, use of consistent terminologies, and best practice guidelines that were sourced from evidence and validated research. And so that's the purpose of INACSL. Where that comes together for our MP faculty is taking simulation to the next level and making sure that these standards are applied for graduate level learning. That's it.
So taking a look at the history of our standards, INACSL first began working on the standards back in 2009, and it took them about 2 years before they published the first set of standards. And those standards have been revised on an ongoing basis, and in 2017, the most recent standard was added to our INACSL Standards of Best Practice, and that was the standard called Operations. So where do you find INACSL Standards of Best Practice? INACSL's website is inacsl.org. You can also find them at nursingsimulation.org. I did send you a copy of the standards yesterday, and the document that I sent has all of the standards except operations, and we'll send that one to you separately. So we have 9 standards of best practice, and as Dr. Davis said, we will take a look at simulation design today, and many of the terms that you saw in the video are listed here on the standards. So today we'll touch on them and briefly introduce them, but as we progress through the 5 different presentations, we'll go into more depth on those individual standards. So what is simulation design? Simulation design is a simulation-based experience. It has purpose, and it's going to allow you to identify your objectives and help you think about and optimize what the expected outcomes are. So INACSL standards provides a foundation for evidence-based practice, not only in academia, but in practice and research. And it reinforces that simulation is a state-of-the-science teaching and learning strategy. A well-designed scenario can be viewed or compared to that of a professional stage production. So when you think about a professional stage production, when you're designing simulation, you have to have a script. So your script is going to include documents for not only your instructors, but for your faculty that are facilitating the simulation. You should have a learner document that gives the learner the information that they need to prepare and participate in the simulation. And all of the equipment and supplies that you're going to need, you need to develop those lists in advance. So with the professional stage production, you have directors. So with simulation, your directors are going to be your faculty, and you have an audience. Your audience is your learners or your students. So with simulation, you want to take a systematic approach to simulation design and ensure that we include our intended outcomes, the context, as well as our objectives and goals. So once the outcomes are determined, you want to then determine what the context is going to be. So context can be the type of case, or the patient, what fidelity you're going to use, what equipment, what supplies. And then you want to think about the goals and the objectives. So with goals and objectives, what do you want to achieve? What knowledge, skills, and behaviors do you want the learners to acquire through participation in a simulation? And so design templates are a great tool to help you and assist you with creating that scenario. And your scenario with a production can be compared to something like a storyboard.
I'm going to ask you to get out your cell phones, or if you have another screen, we want you to go to www.mentimeter.com.
What is that? Menti? I can
Or menti.com, M-E-N-T-I.
Okay.
And it should ask you for a code. We have the code at the top of the screen there. And we're going to have you enter your responses. You can do multiple responses, just whatever comes to mind. Once you're there, in regards to your experience, what is the purpose of a needs assessment? And so,
anything that pops in your mind, word, phrase, something done.
Any ideas, concepts?
Identify the student's need, understanding what the learner needs and wants.
What changes need to be made?
Purpose and goals, right?
Yeah, we got that twice. Perfect.
All right, so this aligns, I'll just say real quick, with what we understand as educators to begin with. We have to know what our students' needs are, or what they need to learn is kind of the foundation of where we're going to start our simulation design from.
Mm-hmm. Absolutely. And in simulation, a needs assessment can also be your stakeholders. So, and your participants are future clinicians. So it's anything and everything that would cause the need to do a simulation, or a problem identified that can be solved through a simulation. So perfect. Are there any questions about that? Okay, that one's pretty self-explanatory. Perfect. Okay, so your simulation design criteria itself is made up of 11 criteria. So the criteria are what must be met in order to have a proper design simulation. So perform a needs assessment, which is what we just talked about, and we all know how to do that. We've done that as faculty. Construct measurable objectives. So you always want a purpose, a driven, not just because I want to do a simulation. Well, yeah, that's a great reason to do a simulation, but what's the deeper need? Like we said, what's the need assessment? And it can be anything from you've noticed your students are struggling with a focused assessment, or you notice your students are struggling to identify when sutures are needed. So it can be a task, or it can be a concept or an idea. So then you build the simulation plan, like Sherry was saying, like your stage production, your plan with your purpose, and you need a theory and a modality. So the most common theories in simulation is the book that we gave you. So the National Need for Nursing and Pamela Jeffries. So Pamela Jeffries, have y'all heard of Pamela Jeffries? If you haven't, she is like the guru of simulation. She used to be at Johns, I think she's still at Johns Hopkins. She's traveled around quite a bit, but she's wonderful. And she actually developed the first framework for simulation. So her theory started as a framework, developed into a second level framework, and is now a mid-range theory. So it's actually really been interesting, even in my 15 years or so doing simulation, to see a framework develop into a mid-range theory. So it's really, really interesting. And then modality. How are we going to do this? Are we going to do virtual? Are we going to do in person? So And remember objectives, and I know y'all know, you always want your SMART objectives. So your goal is the big, what do we want to do? And I always think of my objectives as, well, how am I going to do that goal? Those are my working pieces, and I want those to be SMART. Sherry or Amy, y'all have anything else to add on that?
I think you got it all.
Do y'all have any questions? I know Jessica always uses SMART goals, right? Mm-hmm. No, SMART objectives, always, she says. Okay.
So we're going to do one more Menti. So if you're still logged in, what resources have you used to develop new simulation scenarios? NOF Guide, number one answer, clearly. LSU Library and personal experiences, evidence-based guidelines, case studies, NOF templates and STC scenarios.
Mm-hmm. Fantastic. And just to touch on NSTC scenarios, just so that y'all know, the NSTC scenarios that we have are from CAE. So CAE is the large producer of the MediMen that we have upstairs and the HPS, the adult guide downstairs for anesthesia. So CAE is a trade name. So they're called PNCI, and we can get into that later, but they are evidence-based, and they are they're not just thrown together. So they're really well done. And CAE updates those every, so many years, 5, 6 years. And so we do that as well. But we can also create our own. And we have a template to do that because those undergraduate sims, and Leanne and I have done this for the, what did we do that for, Leanne? For the...
critical care?
For the APRN workshop. We actually took one of our, and we added a column to the right for expected advanced practice outcomes, or what we expected them to do. So we have several formats that we can do. And that kind of leads into criteria 4, is designing the scenario. So you want to design it so that it's as real as possible. And it's hard, and especially hard, it makes me think of you, Jessica, with the Marfans. So Jessica and I did a Marfans, and it's very hard, but it might be easier now because we can, we have some simulators that can look more like a tall teenage adult or a tall teenager, but it's hard for the students to not look at us if we're trying to be the voice of the scenario. So sometimes high fidelity is easier to design versus the case study or the standardized patient, which we unfortunately don't have right now, but we could. But you always want to design it to have that realistic context as much as possible. So that's why we developed that NP simulated clinic room for y'all, to try to look as real as possible. Or like when they came for the APR and procedures, we were in the room that looked more like an ER. So just depending on where the scenario is based, we try as much as possible to do as real as possible. And then fidelity. So fidelity, to create the required perception or realism. So what is fidelity, y'all? We said we weren't going to talk too much, and I'm talking too much. So what does fidelity mean to y'all? If I say high fidelity, what does that mean?
As realistic as possible.
Absolutely. It's replicating realism as possible. So your high fidelity is the highest level of replicated realism. So something that's interactive and reactive. So that's why our MediMen simulators and our HPS are considered high fidelity, because you interact with them and they can react to what medications are given, what interventions are given, versus the nursing ands. For those of y'all that are in advanced health assessment that are in the hospital lab, those are moderate fidelity. So they don't have all the functions of a high fidelity. For example, they have breath sounds, but they don't have chest rise. And then your low fidelity are going to be your static mannequins, just your old-fashioned mannequins that we all had in nursing school. Y'all know what I mean. Or your task trainers. Your task trainers are simulators. So Jessica, your pelvic models, the skin suture pads, those are all task trainers. And then standardized patient, what level of fidelity is an SP? What do y'all think?
High, right?
Absolutely. It's high. I mean, it's a human. Absolutely. It's as high as possible. But there's some intricacies with standardized patients and some training. So supposedly when we move to the ILH, we're supposed to have the whole first floor is supposed to be a standardized patient program for the Health Science Center. So I'm excited about that because that will be fantastic for y'all too. And remember with fidelity, you can mix it up. You can use a high fidelity simulator and then you can have a task trainer. So you can do more than one fidelity at a time to meet your objectives. Okay? And then to maintain a facilitative approach. So what do I mean by that? What does that mean? What does maintain a facilitative approach?
Guide the process.
Right. I'm sorry.
What's that?
I said guide the process.
Mm-hmm. Yep. And this takes practice, I'll be honest with you. As a new simulation faculty, I probably facilitated either way too much or way too little. So it takes time and it depends on the level of the learner. You know, and I'll just use our undergraduate students. For example, our foundation students, we tend to facilitate a lot more than our management students who are fixing to graduate. So the same thing, and poor Jessica, you're the only example because I've helped you with that Marfans. They were kind of like middle, weren't they like middle in the program? So we kind of guided them,
Right.
not too much, but we could tell if they were stomped and really missing something. How do you know when to step in? So that does take time and practice to know how much and when to facilitate. And it depends too on if you have a formative or a summative simulation. So what's the difference? What's a formative simulation? Jessica, what's a formative simulation? I can see you.
Okay. So a formative is when you're kind of evaluating their progress and just, I guess, like kind of helping them along, teaching them with it, where summative is where you're doing a final like evaluation of where they stand. But it's there kind of some overlap in it as well.
There are, perfect. And we have a lot of overlap now. And we need, and not even in undergraduate and graduate, and we should really clear those up. And the students should know going into the scenario, this is formative or this is summative. And if it's summative, we as faculty should not facilitate at all because you're seeing what knowledge they've formed over all their experiences and they should get a grade versus, yeah. But that's later on too. So very good, Jessica.
Thank you. I want to ask the group, how do you guys feel about, so the NOF guideline, the template, there's a section where before they're going for their simulation, you're to give them resources on, like, to prepare for the case. So, I mean, some students look at it and some don't, right? But like, how do y'all feel about them being able to prepare for what they're about to go into? Because in reality, you don't know what's in that room when you go in there. So I feel like that's probably okay for the formative evals because, again, you know, you're helping them along. But how do y'all feel about giving them so much information? And they don't have anything specific on the case, right? They don't know if it's going to be male, female, or the specifics of their history. But they know they're going to take care of somebody with drug abuse, or they know they're going to take care of an elderly person, or they have an idea. When it's my experience in real life that you don't have that. I don't know. How do y'all feel about it?
I get what you're saying, but I guess also too, you don't know until you show up necessarily what you're going to get that day, but you do get a little bit of information, before you go into a room, So when I get those weird complaints in the ED. The nurse says the mom's worrying about a limp for 3 months. I can kind of do a little bit of digging, first, or if I get a weird history, like we had this kid come in with this weird rash, diagnosed already. So I looked it up before I went in the room. So I get what you're saying. We don't want to over prepare them, but I do think giving them a little bit of like, this is going to be, simulation might deal with sudden vision loss, and then they can kind of start reviewing some of that. I think that's fair to do, but I agree. I wouldn't say, okay, guys, go research everything on Marfan's, if you're going to do something on Marfan's.
And I think too, just like what we were talking about with a facilitative approach and level of, so if you've got your brand new BSN to DNP nursing students and they're in their first simulation ever, I might prepare them a little more, especially, it just depends, versus your ones that are fixing to graduate. But it's up to you too, because when they graduate as an NP, they're not expected, they're expected to be practice ready, right? So it's that fine line of how practice ready is a new graduate, or, are you designing a scenario in real life where you would give them, like Melissa said, a little history, and maybe you're at the very end of the program, you say you have 5 minutes to prepare, or something real. So what level of fidelity are you going to give them? What level of experience? And what's your purpose and your objectives?
That's what I would go back to. I think it all starts with the outcome you want from the student. I think when Allison first came and I was still in critical care, I think that was our biggest point of contention, where in critical care, we have them do simulations and we expect them to perform. They get a lot of information ahead of time. So we want to suspend reality and allow them to make their own decisions. And in the debriefing, we wanted to debrief the decisions that they made, because it was all about, that course was a culminating course where everything kind of comes together. You have to analyze, you have to synthesize. It was very high level. With that being said, students messed up, but that is not how they were graded. We wanted to use their experiences to debrief their decision making. So why do you feel giving that drug was safe? Okay, the doctor ordered it. Okay, the NP later on, I was like, okay, call the NP instead of the doctor. But why is it safe? Is it safe to give that drug although the doctor ordered it? What led you to believe it was safe? What data can you use from the experience? So now that we move to the NP program, the outcome is pretty much the same. We want to suspend reality and allow them to make decisions, but depending on the outcome. So it's my personal opinion that giving them information does not guarantee that they're going to perform well. I don't feel that if we said, hey, this is a vision loss case, go in there, do this, and that. We know that real patients distract students. We know that their anxiety gets in the way because that they have real anxiety to this simulated case. Like, there are some barriers. So to maintain and to try to level the playing field, I think providing a learner with doorway information or, a heads up on something is fair, because to compare them to a practicing NP is not fair. Does that answer the question? So my personal philosophy is I want you to come here and mess up. I will facilitate, but I also want it to be a safe space so that you can make a decision, feel it, and then learn from it.
I agree. Some of those are part of the design. We'll talk about pre-briefing in a minute, debriefing in a minute, and just remember that most learning, research has shown, most learning and simulation happens during debriefing. So it's hard to answer that question, Jessica. So that's unfortunately one of those, it depends.
Yeah.
It wasn't really a question. I just kind of wanted people's thoughts, and that's what y'all gave. So I appreciate it.
You're welcome. Okay. So
I think giving them, information that's going to help them be prepared is okay, but you definitely don't want to give them the details of the stages of progression, the actual orders, the interventions that you want them to carry out, the actual care that's going to be delivered during the simulation. Those should all be a surprise, and they should get that when they come in and read the background, the information, and the orders and the patient's history. But to know that in a generic way you're going to be caring for this type of patient, I think that and the objectives and the expected outcomes are okay for them to have in advance.
Perfect. Okay.
I think that's a point that often gets confused with what you tell students and what you don't tell them. Is telling them it's a no-no to tell, you don't want to tell them what the script is and what's going to occur, like you said, but pre-briefing with good information is, and preparing them in that way with the knowledge is certainly a boon to their learning.
Yeah, because I've seen some students, not here, I've seen some students in the past come in cold, and that's the way the school liked to do it, and it actually impaired their learning because they were so nervous and unprepared. So, yeah.
Yeah, I think the little bit of information that you give them in advance would give them an opportunity to research pathophysiology and background information on what would I do, how would I proceed with caring for this patient, what would I expect to see in my assessment findings. So just kind of allowing them to kind of research their pathophys and background.
Yeah, that's a great question.
Mm-hmm. Okay, next.
So our last mentee, and we've got one more actually immediately after it. So let's just have some words. What comes to your mind when you hear the term debriefing? Release of emotions.
I like that.
Yeah, talking about experiences, opportunity, learning, review, lessons learned, check-in.
Those are all perfect.
Yeah.
Debriefing is so crucial, and there's a whole standard on debriefing that we'll talk about more. But yes, always debrief, even with your summative. And we'll talk more summative versus formative debriefing. With your summative, you may be giving feedback, but you're still debriefing so that they can learn from what was done or not done. Okay.
And then we're going to do on the flip it again, and we're going to ask you what comes to your mind when you hear pre-briefing. Introduction, set the stage, opportunity to prepare, preparation.
Respect. I like that. Nice.
Absolutely.
So pre-briefing is actually a newish term. It's not new, but to have labeled it, and there's actually not a lot of research on structured pre-briefing. So pre-briefing is absolutely everything that is said here. And it's also your opportunity as faculty to set your psychological safety. And we'll talk about that more, expand on that too. And pre-briefing, the little bit of research is out there on structured versus unstructured is really, really interesting. And we'll talk about that more right here. So who right now pre-briefs their students? Does everybody here pre-brief? What do you tell them, Abby? I'm interested in your psych mental health. What do you tell them before a psych mental health sim?
Basically, when I pre-brief, I talk about the process of how we're going to do it, because the last couple of times we've done it, it's been over Zoom. So I talk about that we're going to go into a breakout room, and then I'm going to take students one at a time. And usually when I do a simulation, I have some of the students doing sim, and then the rest of them are taking a quiz in the breakout room. Then I discuss like the case, the scenario that we're going to have. And then I talk about debriefing, how we're going to do the debrief, and then what I want them to do as far as to make out and do their SOAP note and submit it.
Perfect. Anybody else want to share? Melissa, how about you? How do you pre-brief?
Very similar to Abby, just giving them a little bit of setup about kind of, you know, first off, a little bit about the case, but more of kind of their setting. Are they in a, you know, urgent care or primary care clinic, so they can kind of get that mindset and where they're, you know, where they're kind of supposed to be. And then I also, you know, how we're going to run it, and then also to kind of just remind them that this is for their learning, that, you know, it's okay to ask questions. It's okay, you know, if they feel like they're making a mistake, you know, and that we'll have a chance to kind of discuss and you know, discuss afterwards too.
I actually tell them not to ask questions, to make the decision and move forward, and we'll debrief after. I also ask them I orient them to the room. So particularly if it's a high fidelity, like with the central line plate, the shock scenario we did for the APRN procedures, this is the patient, the telemetry monitor, the heart monitor, the 12 lead if you need it is here, the crash cart is here. If you need to drop a line, then you would drop a line using this task trainer. Don't use the simulator, things like that. And I tell them to you know, I don't say it like this, but in essence, don't look at me or think that I'm going to give you, you know, the answers, because sometimes they'll try to read your face. And I don't want to give them visual. I don't want them to misunderstand my flatness. I try to be flat anyway. Sometimes I laugh, but my flatness to be that they're doing something wrong. I want them to ignore me completely.
Yeah, Leanne, thinking about that, a lot of times the nurse anesthesia program in their simulations when they pre-brief, they tell the learners, treat us like ghosts. I'm not here. They want that to truly be a student-led and a student-run simulation or experience. That pre-briefing is really how you set the stage. What you say in pre-briefing really will preempt how they perform in the scenario, and you really want to create as much realism and allowing them to perform and do everything they would as they would in a clinical setting. I tell them, keep it real as possible. Actually do and perform the skills. Don't just verbalize and say, I would do this. Do it.
Do it. Absolutely.
In clinics, and right? All my students are in clinics. I don't have any hospital, like what Dr. Fowler was just saying. I don't run any scenarios like that. So what I do is I tell them what they would see. Like if they would just walk into the room, your patient looks like whatever the patient would look like as best as I can. And I usually give them what information the nurse would have given them, like the vital signs or whatever the patient told or communicated to them. And of course their setting, you know, you're in an urgent care, you're in a clinical primary care site.
And, you know, when Leanne talked about orienting them to the room and the equipment and the simulator, that can really decrease a student's level of anxiety, just having that opportunity to get a little orientation to the room, especially if they're not familiar with the simulator. And high fidelity simulators can be intimidating because they don't know what the features are and what the simulator can actually do. So with our beginner students, I spend a lot more time orienting them to the room and the equipment and what they can do and putting their hands on the simulator to kind of ease those anxieties.
Mm-hmm. I agree. And those are all really, really good answers, discussions, and we'll talk about pre-briefing more because it's so crucial, but consider it almost like directions for a test.
Yeah.
directions on how to do something. The more the student hears the same thing, the more comfortable they are and the more they'll be able to perform instead of focusing on, ooh, can I do that? Ooh, can I do that? And they're safe and they know that, yes, you can intubate that patient. Yes, you can insert that central line. And then debriefing. And so, like I said before, so research has shown for years that so much learning occurs in debriefing. Have any of y'all ever seen the light bulbs go off when you're debriefing?
I love it. I love it too. That's my favorite part.
Yep. And so there's several ways to debrief. So there's simple, anyway from plus delta. Has anybody used plus delta? You probably all have.
Mm-hmm.
Well, and the worst thing I've ever heard, and I heard this once, like I said, not here, is what did you do wrong? No. What could you have done better? What could you improve?
What would you do differently?
Do differently. Yeah. You never want to like cut that student down because then their anxiety is, it's up and they associate anxiety with, oh, they're going to just chew me out with simulation. No, it's a learning experience. There's GAS. So GAS is gather, analyze, and synthesize. So and that's why we, just as a side note, we promote a 2-faculty simulation model. So somebody to run the simulation equipment, us, and a faculty content expert, so y'all. Because as you're watching the sim as a faculty, you can gather what's happening, what's going on without having to focus on the equipment. And then during debriefing, you analyze it. Well, I noticed you decided to draw a CBC. Explain to me why. And then you synthesize at the end. Okay, so in summary, tell me what you did. There's one called Debriefing for Meaningful Learning. It's kind of complex. It's once you get a hang of it, it's kind of complex. There's several, and I'm forgetting most of them. The ones, Pearls. So Pearls is really good. And then good old Socratic questioning. Leanne, how do you feel?
That's the first question I ask, actually, because usually they are like,
yeah, and they're all very, very self-critical. They always want to talk about what they did wrong. First. So I make them talk about what went well first. I make them. And they're all very self-critical. So I always end in a high note. And then, yes, I forgot. My mind just, it's okay. Debriefing is a criterion all for itself. So we'll talk more and more about it and we'll practice it. I use Socratic questioning on my children. It's fabulous.
Is there, and we may get into this later or at another session, but is there a recommendation about group debriefing versus individual student debriefing, or kind of depending on what your aim is?
I would say depending on your purpose, your aims, your objectives, absolutely. Informative versus summative.
That's a very good question.
That's a great question.
I would say, especially if you haven't done a lot of simulation with the class, to set it up and to let group be first, so that they have each other to lean on and not feel, picked on or anything. But if you are evaluating performance of an individual, then it needs to be individual.
And to me, silence is very hard because you want to answer it for them, but really give them a little bit to reflect, and you'll be surprised on what the responses are. They know the information, they just are reflecting back. So silence is an art form within itself. Absolutely.
So going back to group debriefing, Melissa, if we're running more than one sim lab, and say we have a group of 5 students coming in and they all participate in the same room in the same simulation at the same time, we would debrief that whole group together. But if Allison was debriefing in one room, if Allison was simming in one room, I'm simming in another room, then Allison and I at the end of the simulation would not go together and debrief both groups together. We would keep those groups separate. So if you are doing a simulation with 1 or 2 students and they're in the room together, participating together, you can debrief them together. But if you did a simulation with them separately, you wouldn't want to bring them together after and debrief together because their 2 simulation experiences could have gone very differently. And you want to debrief those experiences separately.
Yeah, thank you. That's kind of what happened my last time. I usually bring them together, even though they might do the same simulation. I have 2 students right now at different times with me. I would bring them together, but this last time I just ended up, after the simulation, we just started kind of talking about the scenario and getting into some of the, reviewing some of the pathophysiology with this simulation. So then I did the same thing with the other student, and then we didn't have time to meet, the 3 of us together afterwards. So I was kind of wondering if that's okay, but it probably in this case worked out a lot better that they debriefed individually.
Yeah, sounds like it.
That's how I do it.
Go ahead.
I was just saying that's how I do it. I immediately debrief right afterward.
Yep. And that is best practice. You don't wait 30 minutes, don't wait an hour unless, of course, things happen. But the sooner you can debrief after the experience, the better. Mm-hmm. All right, so let's go on to the next things. I'm looking at the time, and we have a whole session on debriefing. So evaluation, and we'll expand on this as well. So just put thoughts in your mind right now. Are your simulations graded? Are they pass-fail? Are they participate only? In formative and summative, and we'll talk more. So just have those thoughts rolling in the head right now. And we've kind of already talked about 10 right now, participant preparation materials and resources. We kind of touched on that with Jessica's really good question earlier. And then 11, so trial or a dry run or a pilot test on the simulation-based experience. So if it's something is new and we've not done it, it's really, really important to trial it. And we even, you don't have to go through all the stages in super depth, but you'd be amazed at what you catch on, ooh, that doesn't work, or that doesn't make sense, or I really need so-and-so equipment. So it really is important to do a trial or a dry run, especially of a new experience that's been developed. And it can be, an hour before, it can be a day before, whatever we're comfortable with. It really helps it to flow better, and the students have a better experience, and everybody looks really professional because we've already trialed it. Absolutely. And even with trial and dry runs, sometimes unexpected occurrences happen, and that's okay. You can still debrief about them, or you make a little note and you adjust later, because students don't know that you really planned for an A-line insertion and they did an IV, or I don't know, that's a terrible example, but you know what I mean. Okay.
So y'all did mention the NOF templates, and I just put a picture of the NOF template as well as an NLN simulation design template. And I can send you these links via email so that you can get to the NLN website. There are a lot of resources and tools related to simulation and documents and templates that you can use. And you can kind of compare and even use parts of one template and another template to really get the end product that you want to customize and develop that works for you.
Mm-hmm. Yep. And we'll talk more about those templates and designing and developing a scenario too. So I don't want you to think we're just breezing past it. This is truly just an overview of everything. And now, like the little guy says, questions or comments?
Yeah, I want to know when we're writing a book on this, because I just need money to just be mailed to me. I was just thinking that. And just like open it up and like the money just be sitting there.
Yeah.
I can have that, right?
Yes, we can.
We absolutely can, especially if because we will, I'm sure, write some NP-focused scenarios that are, evidence-based and have all the pieces, objectives and SMART objectives and blah, blah, blah. So this is a 3-year, I know you don't want to hear that, a 3-year professorship. So maybe the end of year 2, we can start putting something together.
I agree. And also there's very limited information about psych NP simulation. It's very limited.
Yes, and I have one over here that I've had forever, and it's about a transgender individual, and you never touch the simulator. It's all about communication and interviewing. It's very powerful and very good. Mm-hmm.
We're talking about our book, Leanne. You missed it. We're writing a book.
Mm-hmm. Awesome. Awesome. I'm down.
Absolutely.
All right. Not
Any
just
other
an article, but a book. Got it.
Maybe both.
Mm-hmm.
I don't have any questions, but I really appreciate you guys leading this and developing this for us. It'll definitely give us a good foundation to develop more structured and better simulated experiences.